Beyond the universal megaloblastic findings shared with all forms of megaloblastic anemia, pancytopenia, ovomacrocytosis, hypersegmented neutrophils, and bone marrow megaloblastic hyperplasia, pernicious anemia carries its own specific laboratory markers. The anti-intrinsic factor antibodies discussed earlier are the most specific. The abnormal Schilling test result is the third distinctive laboratory finding. The Schilling test, though used historically rather than routinely today, elegantly identifies the mechanism of B12 deficiency. Here is how it works in plain terms. Imagine giving someone a tiny amount of radioactive B12 by mouth, and then measuring how much of it ends up in their urine. In a healthy person with intact absorption, some of that ingested radioactive B12 will be absorbed and eventually excreted in the urine, so you can measure it. If very little or none appears in the urine, absorption is impaired. The test then moves to its second stage. Repeat the process, but this time also give intrinsic factor by mouth alongside the radioactive B12. If absorption now normalizes, and radioactive B12 starts appearing properly in the urine, the problem was specifically the lack of intrinsic factor. This result confirms pernicious anemia or total gastrectomy as the cause. However, if absorption remains poor even when intrinsic factor is provided alongside the B12, then the problem is not intrinsic factor at all. The intestine itself is malfunctioning. This pattern is characteristic of intestinal malabsorption conditions such as Crohn's disease, blind lib syndrome, or giant tapeworm infestation, conditions where the intestinal absorption site is diseased or bypassed by competing organisms. The third possible Schilling test result is completely normal absorption from the very beginning, meaning the body absorbs radioactive B12 perfectly well without any intervention. If absorption is intact, the B12 deficiency must be purely dietary in origin, which is the situation in absolute vegetarians and strict vegans who consume no animal-derived products whatsoever. In summary, pernicious anemia is characterized by laboratory findings typical of vitamin B12 cobalamin deficiency, macrocytic anemia with elevated mean corpuscular volume, MCV, low or borderline serum B12, elevated methylmalonic acid, and homocysteine, but it is specifically diagnosed by the presence of anti-intrinsic factor antibodies, highly specific, present in about 50 to 70% of cases, and confirmation is strengthened by the presence of anti-parietal cell antibodies, present in greater than 70 to 90% of cases, but less specific, and evidence of atrophic gastritis. Additional markers may include elevated lactate dehydrogenase, direct hyperbilirubinemia, low reticulocyte count, possible pancytopenia, and low pepsinogen 1 and high fasting gastrin levels if tested. In the next video, we will discuss the causes of B12 deficiency and folate deficiency.